This is Dr. Deepa Sheth. She is a breast radiologist here at the University of Chicago. She did her undergraduate and medical school training at UIC, and then her residency and fellowship training here at the university. And if you want, you can watch her talk about mammography on Windy City Live if you go to her faculty profile. But she's going to talk to us today about screening for breast cancer and mammography and all things radiology. So I'll turn it over to her. Thank you.
Yeah, thank you, Dan. I appreciate it. I know this is such an awkward time for everyone, having to speak through Zoom and virtual, but you know, we just have to embrace this time and appreciate the fact that we can at least communicate even during times of pandemics, right? So I want this to be casual, very comfortable, relaxing, inviting. I want you guys to interrupt me. I will be checking this chat box if you guys want to just kind of text your or question if you want, not a problem at all. But interrupt me. Like, the whole point of this is for you guys to just be as engaged in this conversation and learn and be as passionate about radiology as I am, and particularly like community-based radiology, which is what I'm really all about. So let's get started. I just want to confirm everyone can see the screen. Is that correct?
Yes.
Perfect. Okay, so I'm going to talk about your friendly neighborhood breast cancer center and embedding equity into an image-based approach. Okay, so just like in yoga, we want to set our intentions for this afternoon and for this class. We are going to talk about this concept of risk stratified breast cancer screening and how this really has become a paradigm shift. In this era of precision medicine or personalized medicine, radiology is also sort of hopping on that bandwagon and starting to really personalize our recommendations for women based on their risk for breast cancer. And we're going to talk a little bit more about that. Two, I'm going to talk about how we have several targeted clinical trials here, and they really focus on closing this gap in breast cancer deaths among minority women. We're going to talk about the disparities that exist between non-Hispanic Black and non-Hispanic white women for breast cancer and how it's specifically relevant to Chicago. Do you need me, Reese?
Yes.
What's up?
He's from Milton. He wants to know radiation.
Hey.
He said, do this supposed to be filled out?
Oh, yeah, sure. I can fill it out.
Thank you so much.
Yeah, no problem. My pleasure.
So that's up to Sheth. Details now.
Thanks, I appreciate it.
Meet you.
Okay.
Thank you.
Sorry, I am in clinic, as you can see. So radiologists see patients in clinic. Okay. And then last, we're going to talk about how we can translate this sort of cancer health equity into action and how we can diversify our patient recruitment in clinical trials. Okay, so let's first talk about this word or this concept of disparity. What does disparity mean? You guys can type it into the text box or yell it out. What is your definition of disparity?
Unequal access to resources.
Yeah, I like that, Valerie. Anyone else want to add to that? Okay, we're liking that term. So disparity, just as very similar as what Valerie said, a lack of equality, especially in a way that's not fair. The quality or state of being different from perhaps the standard or from that of others. So then let's take it a step further, Valerie. So let's talk about this concept of health disparity or healthcare disparity. What is the definition or your interpretation of that?
So similar with like unequal access to like healthcare resources for prevention or like treatment or other like social determinants of health.
Yeah, you got it. So health disparity is potentially a higher burden of illness or mortality. Let me close this, by one group relative to another, exactly what you said, right? So you can focus it on tests or you can focus on just actual burden of the illness. And healthcare disparity, as you said, is the difference between groups in health insurance coverage, for instance, access to and use of the care or the quality of care that they're exposed to. So big differences, and it's a really hot topic here in health disparity, especially in times, and it's so relevant now in times of need, like in times of a pandemic. These disparities that already exist in our baseline existence is now magnified, right, or markedly increased as we get through times of toughness or difficulty. And so before we hop into this, if you guys can yell out different types of differences in access or different determinants of health that can separate one person from receiving the same type of care as another person. Yell them out or Shada, put them in the chat box. Like Ryan, Alec, David, Andrew, any of you guys, shout something out. What are some things or reasons why two patients potentially don't receive the same type of care? What are some barriers to them receiving that care? Okay, so we have race, we have gender, distance from the clinic. Oh, I love that. Pre-existing conditions, absolutely. Ability to take time off work to receive care. Ryan, I really like that one. Childcare, like Alex said. Their zip code, their location, language barriers, insurance access, all awesome and spot on. You guys are absolutely right. And there are multiple tables and multiple ways to sort of characterize this, but you guys all hit it on the head. These are all different social determinants of health. And they can be categorized into things such as economic stability, which one person already mentioned, like your job or lack of a job, especially during COVID, right? All of these people citing unemployment and the constant income and expenses debt sort of battle that people face. Medical bills that are still coming in, how do they support that? We can also talk about where you live. Someone mentioned that, your zip code or your geography, and how far that is from the nearest hospital or nearest community clinic for you. How are you going to get there if you don't have a car? What if the CTA doesn't come in that area? What if Ubers don't come to that area? You can't pay for the Uber. How about your education, your language? If you don't speak the language, if you're not an English native speaker, how do you relay your findings or your problems to a healthcare provider? What if you just don't have the education or background to even relay those findings? You don't know how to explain what's going on. How about just basic food? If you have other competing interests that are of greater priority, like putting food on the table, having a shelter for the night, that's going to take precedence over perhaps a growing breast mass, right? Community and social context. If you don't have a support system to help walk you through all of the things that are going on, to tell you that you should go see a doctor, you're not engaged with your community. You sort of feel like you're isolated or an outsider, and you don't feel like you can come into the hospital and feel safe, or you feel discriminated from. And even stress, if you're just stressed out from perhaps the COVID pandemic and you just don't know how to process everything that's going on in your life. And then finally, just a bigger problem of healthcare system, right? You don't have insurance, you don't have provider availability. Your provider that is included in your insurance lives, several miles away, and you don't have any way to get there. And even when you do get there, the quality of care that is provided at that place may not be up to standards or what would be potentially presented in an academic center like University of Chicago, right? So all of these different things that you guys already know and thought about all affect health outcomes. They affect these patients' mortality. They affect these patients' morbidity, their long-term life expectancy, their long-term health status. And like I said, these things can be magnified in times of hardship, like in times of a COVID pandemic. So let's bring it closer to breast cancer, right? So I am a breast radiologist. All I do, live and breathe every day is breast cancer and the detection and diagnosis of that. So I'm in clinic right now. I see patients in clinic, and we work on detecting and diagnosing them. We do biopsies on these patients. So let's talk about disparities in breast cancer. When we talk about disparities, the first thing we want to talk about is the incidence of cancer, the breast cancer in women. So when we look at that, you can see that the incidence of breast cancer between white and black is about the same, right, per 100,000 women. Just shout out, what is the lifetime risk of getting breast cancer? If you are an average female with an average risk for breast cancer, what is your lifetime risk for getting breast cancer? Let's see, I see some chats. 30%, 12%, 1 in 3, 5%. Yeah, so it's 1 in 8 women. So it's about 12%. Good job, Brianna. You were very close. So 1 in 8 women will get breast cancer in their life, and that's considered an average risk. If you are considered to be at high risk or elevated risk for breast cancer, what does that percentage jump up to? So if 12 is average, what's high risk? 20%. You guys are getting there. So 1 in 5 women. So average is 1 in 8. and high risk is 1 in 5, okay, of lifetime risk of getting breast cancer. So if we look at this incidence again, we can see that whites and blacks have about a similar incidence to getting breast cancer. Asians and Hispanics are a bit lower, and then American Indian are lower than that. For instance, when I went to China, their incidence for breast cancer is 1 in 12 women. So they have a lower incidence of that. But when we look at and you can see here, they have a slightly lower incidence. But when you look at the breast cancer mortality rates now by race and ethnicity, you can see that there's a big difference, right? So you can right off the bat see that even though African-American women have a lower incidence of breast cancer, their mortality rate is much higher than Caucasian females. And in the pink chart on the left-hand side, you can see that instead of 20 per 100,000 women dying from breast cancer, in blacks it's 28. And so African-American women are more likely to die from breast cancer. And you can see with the chart on the right, which is in Chicago, you can see that through the years, this disparity has really markedly increased. And in 2005, which is that last data point that I'm showing here in this public health record, that disparity was the most that it's ever been in all of these decades of evaluation, where the breast cancer mortality rate for blacks was almost double that of whites, right? So at 2005 was sort of a turning point for Chicago, where they were looking at these breast cancer mortality rates, and they saw that we had almost double or twice as many African-American females were dying from breast cancer than Caucasian females. So, like I said, the breast cancer rates stabilized between 2002 and 2011 in Caucasian women, but they were steadily increasing in African-American women. And so African-American women were less likely than Caucasian females to survive 5 years after diagnosis, a difference of 70 to almost 86% difference of survival rates. And when they were getting these cancers, we were seeing that not only were these cancers super aggressive breast cancers, but they were seen in women that were much younger. So traditional breast cancer age is about 60s, in your decade of 60s, but these females were in their 40s and 50s. And we were also seeing that they tended to live in low socioeconomic status areas. So in general, compared to white females, African-American females tend to have more aggressive tumors. They tend to be screened less frequently. They tend to have a poor prognosis for a given stage at the time of diagnosis, and we'll see that they have less access to medical care. And so we were seeing that in 2005 in Chicago. It turned out to be sort of this perfect storm, right? Where it's a combination of bad genetics, bad biology, and bad access to care, leading to this huge difference in morbidity rates. And here's just another way of bringing it home in Chicago. You can see that in 2005, when they noticed this, they were really looking at other cities as well, not just in Chicago. And you can see they did a comparison between New York, Chicago, and just the US. And really, it's dramatically different. The death rate for African-American female from breast cancer in Chicago was almost 70% higher than other women in New York or in the US. So this was a huge deal. In 2005, when this was noted, they convened what was known as the Metropolitan Chicago Breast Cancer Task Force. That was combining over 100 organizations and 74 clinics to collect this data and really test a few hypotheses. They wanted to test several hypotheses. One was that African-American females have less access to screening mammograms. African-American females have decreased access to good quality screening mammograms, and African-American females have genetics that predispose them to more aggressive tumor biology than their counterparts of Caucasian females or Hispanic females. And when they were looking at this, they coined this concept called healthcare deserts. This is in Chicagoland catchment area, and you can see that it looks at all the different communities in the Chicagoland area. The green little communities show the highest breast cancer mortality rates in Chicago. So they're mostly Southside Chicago and the western suburbs. And then the orange triangles are the ACR accredited breast centers, right? So in order to be an ACR accredited breast center, ACR meaning American College of Radiology, you have to pass very specific quality standards, not only for the mammogram, the ultrasound, and the MRI. And if you pass all three of them, and they're not easy to do, it takes a lot of sort of attention to detail. You need a lot of staff to help you do this. You need to constantly acquire good quality images, have a good quality machine. Once you get all of that, you become an ACR Center of Excellence. And so you can see the triangles are ACR Centers of Excellence. and very few, if any, overlap with these areas of the highest breast cancer mortality rates, right? So these locations that have these high rates, they're located in the south side. Of these 25 communities that I've circled, 24 of them, majority are predominantly of African American nationalities. They have no access to good quality care. And the good quality locations that are there are pretty far for them, right? So these are healthcare deserts where we know these sites need it the most, and yet there's no location for them to go to. So we very quickly can see that access to care is a big issue, right? That screening, diagnosis, and treatment for these aggressive cancers, for these big cancers at the initial stage becomes very difficult if your primary care clinic is not easily accessible to you. Also, we know that long travel times and waiting times are particularly prominent in these disadvantaged communities, of which African Americans are a majority of. And then we saw when they were doing this census and creating this task force in 2005, they were doing a census and they saw that about 200,000 screening mammograms were performed for women in the Chicagoland community. This community had about 600,000 women. And so right away, you can see that we're not screening as many women as there are in our Chicagoland community. But to add to that, the maximum potential that we even had to perform these screening mammograms was 370,000 women. So right off, there's going to be a disparity, right? To only serving the ones that can access these sites and the ones that access these sites first. Huge disparity in Chicagoland. Questions right now? We doing okay? Okay, I'll keep going. And so furthermore, when they looked at more of this data about now, not just access to care, but access to quality care, they saw that having a regular primary care physician led to twice as likely chances to undergo a screening mammogram. So many of these patients that don't have insurance or are immigrant status and don't have any way to get insured, they're not going to have a regular PCP. And there's no one there to really help them, remind them to get a screening mammogram, remind them to get a follow-up if there's anything abnormal. Also, we see that medically underserved African American females, so those that don't have a regular PCP, we notice that they often access the healthcare system only during emergencies. So only when this mass now has become a large fungating mass, it's coming out of the skin, it's causing a lot of pain, it's causing a lot of bleeding, a lot of smelling. They don't come for screening mammograms for preventive services. And so they fail to benefit from any sort of preventive cares that we have as a system, like colonoscopies, pap smears, mammograms. In addition, there is a system level bias, right? We know that those who provide care to minorities in these Southside centers, in these underserved communities, often are less informed about preventive care services. So it's not going to be board certified physicians that are going to these off sites, going to these low community areas with low levels of services, right? It's going to be these community physicians that may or may not have the proper training to do this. So there's another level of bias here for these patients, for these African American females. And so the chips are definitely stacked against them, right? Like there's a lot of barriers that they have to overcome. And then, like I mentioned, this concept of competing survival priorities. It's really hard to tell someone to get a screening mammogram if they don't have food on their table or if they don't have a home for the night. It just doesn't compute for them. And so we have to figure out a way to help them get their primary needs, their primary survival needs, so that they can then prioritize prevention and screening. And we saw that a higher proportion of African American females are more likely to be paid hourly rather than annually. So you can imagine if you're having to have them take time off from work to get a screening mammogram, which means perhaps waiting for a bus, taking the bus to get there, waiting in the waiting area, figuring out you don't have insurance, you have to do self-pay, figuring out if you can self-pay for the day to get that screening mammogram, potentially going then back on the bus, going back to your work. That's a lot of hours that came out of their wages that potentially people can't afford to do, especially in times of a pandemic, for instance. And lastly, we have to talk about cultural beliefs and attitudes, right? So we know that cultural factors can play a large role in promoting racial disparities in breast cancer care. There are often times when patients come in and say, you know I have a breast mass, but I've been trying acupuncture, or I've been trying different oils and herbs and remedies. And it can be hard to sort of tell them that you're going to need a biopsy, you're going to need radiation, you're going to need chemotherapy. And if they don't entirely trust you as a physician, then they may not ever come back. You may have lost them forever in the system. And so that's a huge thing that we also battle here at the University of Chicago, given our patient population and our patient cohort. We have to sort of help navigate those sort of thoughts and make sure that they are in line with what we're recommending for them And also this concept of what is sickness, right? So for one person, sickness may not necessarily mean a lump in the breast or a growing fungating mass in their breast. There may also be these fears of the unknown. What does a mammogram really mean? Is it gonna hurt? I'm shy of showing my breast tissue to a stranger, to a technologist. I'm afraid of pain from a biopsy, and potentially even just confidence in Western medicine, right? Do I believe this sort of medicine that doesn't talk about acupuncture or herbs and oils and things that may not be, you know, part of our regular protocol? And so when this task force happened, as I mentioned, it really was a big deal because we saw this huge disparity in Chicago, and they took 2 years to really look at all of these different accesses to care, all of these factors that may affect our breast cancer mortality rates, to come up with a way to help unify this process and help bring down some of these disparities, right? Because it became one of the biggest health problems that we faced here. And we see it at the University of Chicago. So at the University of Chicago itself, we've developed several large-scale clinical trials, which I'll talk about, that not only work on cancer prevention and screening, but they really focus on our minority population. We're really working on bridging that gap between these patients that don't have access to care and certainly not access to our clinical trials. But on the other side, we want to create data and acquire images and data that's universally and ethnically universal and applicable, right? So we don't want to just have all Caucasian females in our trials. We want to have Blacks and Caucasians to make sure that any data that we come up with or any guidelines that we come up with is ethnically universal. And so when this task force was created with the Metropolitan Group, they partnered up with us at the University of Chicago to try to look at how we can increase access to care, how we can reduce all of these different risk factors for breast cancer, and increase our participation in breast cancer research. I will talk about a few of these trials that we have in participation with the Metropolitan Task Force, including this, the National Cancer Institute planning grant that we have at the University of Chicago, which is focused on disparities and health equity. And then I will also talk about different types of ways that we have worked through this SOAR of how we change our healthcare delivery patterns and how we change our access to care to make sure that it's diverse and make sure that our research accounts for all the different types of disparate breast cancer, not only in terms of the genetics and the tumor biology, but in the access to care and the ethnic specific sort of differences in the disparity. And in addition, the task force itself also came up with proposed quality measures, right? So some basic measures that they expect all clinics, all community centers, all clinics, all academic centers to follow, so that we can try to unify the type of care that we provide to these females, no matter where they're located. And some of these like quality measures are actually really, really straightforward and easy to reach, right? So if you take a look at some of this, and it says proportion of patients referred for screening mammogram. Well, they want to try to get 100% of their patients in there. But actually, how many receive them annually? Only 80%. So they're assuming a 20% drop-off rate. That's a huge number of patients that they're saying is okay to have dropped off. Here at University of Chicago, we want that to be 0%, right? So you can see that we've tried to really lower this threshold to an amount that's acceptable for even community centers that don't have navigation, that don't have these automated, you know, AI sort of savvy programs that can reach out to patients and make sure we're tracking them all. If you take a look, the amount of tumors that are found at stage 0 or stage 1, that means really small tumors, they're hoping that greater than 50% of their patients will have really small tumors. It's a nice goal to have, right? Like that means that we want to screen patients, we want to screen them annually so that God forbid something does come up, it's at a small enough level at a stage 0 or 1 that we catch them, right? If you take a look at their follow-up, proportion not returning for follow-up within 60 days, less than 10%. So here at our follow-up is less than 30 days and we want it to be 0%. And so we're making these thresholds a lot easier. We're saying within 60 days, and we're saying we're giving you less than 10%. Here, number of days from abnormal screening to initial diagnostic workup, 30 days. That's great. Here we get 15 days, right? So you can see with all of these different metrics, they're trying their hardest to have some metric for the clinic to follow, but to have it easy enough and reachable enough that it's not so intimidating to get, right? So that clinics don't just give up and say, we're not going to provide any more breast cancer care because we can't reach any of these metrics. And in addition, when we created this sort of relationship and collaboration with the task force, what we realized is that there's a need for 3 different core things at the University of Chicago in order to make sure this happens. The first thing is navigation, the second thing is transportation, and the third thing is financing. So in terms of navigation, that's really key, right? That means that you take a lay person from the community, and you want a lay person. You don't want someone that's got a that perhaps has a lot of educational background. You want someone that looks like the communities that they serve and can really speak to them on a level that makes sense to follow these ladies, to make sure that they come for their screening mammogram, to make sure that they follow up if there's any abnormalities, to make sure to come for their biopsy, make sure they stop any blood thinning meds if they're on any. And it's not just for this year. It's about then, okay, how about next year now? Let's follow them all over again. Let's get them all in for a screening mammogram. Let's follow them if there's any abnormalities, right? So it's a long-term commitment to the hospital and to the community, to these patients that we serve, to make sure that they continue to get the preventive care that they need and they deserve. And when we started doing that, just at the University of Chicago, we noted that our mortality rate dropped by almost 14%, right? Patients were coming in on an annual basis, and we know mammograms don't prevent cancer, but they catch cancers at such an early stage that we can drop their mortality rate. We catch it in an early stage where it hasn't yet gone to the lymph nodes. It hasn't yet gone to the rest of the body, and we know that we can increase their long-term survival. Transportation, that's a huge one, right? Not only is it hard for some patients to take time off of work and come to work and find a CTA, wait for the CTA, weather can be incremental, like it can be all hard, but especially during COVID when all of these things were gone, how do patients get into the hospital to do that? So we've partnered up with Lyft. It's called UCars. And if patients can't afford to have transportation to come to the hospital, we pay for that. We pay for that, and it gets covered under our sort of special funds that we have for these patients, and we get them here to the hospital through a Lyft ride, and then we send them back home through that Lyft ride. And that has immensely helped us out too, in getting these patients to come in for screening mammograms or getting the workup that they need when we help pay for their transportation. And especially, like I mentioned, this concept of healthcare deserts, where there is no site that's close by to their neighborhood, we help provide for that transportation. And then finally, payment, right? So especially now during this time where patients are filing for unemployment, how do you get them into our university when they don't have insurance? For the longest time, and before this task force was convened, we only took patients that were insured. And yet here we are in the south side of Chicago, and we can't serve the community that we live in because of this requirement. And ever since this task force took place, we now have partnered up with the Metropolitan Task Force and IBCCP. It's called the Illinois Breast, Cervical, and Cancer Program. What that does is we pay for 150 slots every year to allow for free breast cancer screening, free cervical cancer pap smears, free diagnostic workup. And it's 150 patients every year for free. If the patient gets diagnosed with a cancer, then at that point, it's covered for them to apply for Medicaid, and we help them with the application fee, and all charges then are retroactively charged to Medicaid, so the patient doesn't incur any of those. That's new, and it's revolutionized the way that we take care of patients. For the longest time, we couldn't take them in our hospital if they didn't have insurance or if they didn't have a PCP. We just wouldn't even give them an appointment, for goodness sakes. And now, because of IBCCP, because of this navigation system that we have at UFC, we're able to take in these patients from the south side. Now, is it perfect? No. There's always ways for us to improve. Applying for clinical trials like we have, and I'll talk about in a little bit, that's really helped us gain more, not only money, but more attention to this cause, to help really set up an algorithm and a navigation system in our hospital to justify this. But ultimately, it comes down to money, right? So the hospital loses every time we take in these patients without insurance. How do we justify this? It's sort of like what Stroger goes through as well, right? Like how does the hospital keep afloat when they're taking in patients that can't pay for any of their services? And so that's something that we always have to battle with the hospital and have to justify that, look, we're catching these cancers. Ultimately, it's going to bring back money when these patients get their treatment, but it is very difficult. So I have a question from Vivek. It says, has that retroactive payment system been added to other programs at U of C? I've known people that have waited 6+ months for Medicaid and still couldn't get it. So it'd be amazing to see this in other departments too. Yeah, I agree. I know that since U of C has opened up their level 1 trauma center for adults, this has become a really big deal because the patients that we see in our trauma center are, for the most part, uninsured. And so they have a whole department now that helps them actually fill out applications for Medicaid while they're in the hospital, while they're in the admission, and it will cover retroactively all of the services that and care that they received during their primary admission. And so, yeah, we're really working on that. We acknowledge it, we appreciate it, and we have a team of people that purely work on this Medicaid portion of patients that come in. I mean, to be honest, before this happened, most of our patients that came in were through the ED. They would come in with these large fungating masses that were almost 10 centimeters. They couldn't even get a mammogram because it was literally coming out of their breast, like coming out, you know, and it was like invading their chest. And then while you're doing the ultrasound, they're telling you they have back pain, they have leg pain, and now you know they have bone mets. I mean, that's the kind of patients we were getting. It was rare to get these nice, beautiful, screen detected, you know, 1 centimeter masses that we catch like we would potentially at North Shore, for instance, or Northwestern University, where it's a totally different patient population mix. And so with this system, this retroactive payment and having a dedicated Medicaid team, it's really helped us. So as we're seeing, there is this concept of there's a huge need in our community, and UFC and specifically the breast cancer section, including me as a radiologist, have made a commitment to our community. We understand that when it comes to cancer, especially breast cancer, not all Chicagoans face a similar reality, right? And here, just this past year, we've developed something called the Office of Community Engagement and Cancer Health Equity Department. It's called OSECHE. And what we do is that we collaborate with researchers and we collaborate with physicians that are on the ground to help address some of these obstacles in cancer disparity through research, advocacy, education, development of innovative programs. And so the hospital is really embracing this. Since I'm part of it, obviously you can see that a lot of it has to do with breast cancer because that's what I'm super passionate about. But we're trying to address this in other fields and other cancers as well. The other big one that Dr. Neeta Lee does is cervical cancer. So she's created her own cervical sort of cancer education program. She has patients come in and learn more about it. Families come in. They provide free pap smears through IBCCP as well. So me and Neeta communicate quite a bit to get patients not only their mammogram, but their pap smears. Me and her have also done mammal parties, you know, so I actually have a bus of ladies from the community that come in. We get them all a medical record number. We get them a PCP. We do their screening mammograms on a Saturday so that they're not interacting with any of the hospital members. They just come in and we're dedicated only to them. We read their screening mammogram that same day. And if there's anything that needs to be worked up, we work it up that same day. So we're really trying to do more of this stuff where we bring in these patients using all these mechanisms that we've discussed. And like I said, you have to have buy-in from the hospital too. This is the only way this is going to work. And so we've really worked hard with our patient access folks and our financial services folks to collaborate with and to really create this infrastructure for our minority populations, including, like Vivek mentioned, this whole Medicaid component to it, to make sure that we are also looking at being mindful of the financial aspect of all of this care, right? So it's one thing to be super passionate about community outreach and service like I am, but then I work in a big academic center. I have to justify what I have to do. I have to justify my time here in clinic. I have to make sure that I'm being productive and bringing in dollars, right, for the hospital. So this is one way to do it. If you bring them to the table to talk about this, that's how the hospital then starts buying in. They start seeing the value in what you're doing. And in fact, they're going to give me another navigator to help me do more of this in the community because they're seeing value in this, monetary value in this. Okay, so just a few pictures. We've also created our first ever.
Sorry to interrupt. There's a question in the chat box.
Oh, for sure. Is it just the one from Vivek? Because I did answer that, I thought.
I'm sorry. I apologize.
Oh, no problem. Does anyone else have any other questions? This would be a good time to interrupt me. If you're shy, just type it into the text box, no problem. Okay, then maybe I'll just keep going if you guys are okay. So this is just a few pictures. We started our first ever breast cancer support group, and so we called it Wonder Women. These people are actually from Metropolitan Chicago Breast Cancer Task Force next to me, so that was really cool that we got them to come along to the breast cancer event. This is just other advocacy folks, sisters working it out with us. And our first event was on nutrition. So we had Dr. McDonald from GI talk to the ladies about the impact of nutrition on cancer. Hey, what's up? Okay, sounds good. And we actually had the ladies make kale salad, zucchini noodles, and power granola balls just to show them like nutrition doesn't have to stop at the hospital. You can take all of that home with you. So that was really cool. And this is sisters working it out and Metropolitan buying us groceries. And then I'll talk about some of these trials, but we really do go out to the community to advertise some of these wisdom studies that I'll talk about, the CAPS trials. We really try to engage with the folks in the community to teach them all about breast cancer and breast cancer disparities. And this is me going to Chinatown. I gave a talk to a bunch of ladies in Chinatown. It was funny because all my slides were converted to Chinese and I honestly had no idea what they said. I was just like trying to go off of what I thought they had said. And then I had a Chinese translator right here who interpreted everything I said in English to Chinese. So that was a cool experience. And then we brought all these ladies on a bus over to U of C to do mammograms for. And then this is a poster of me in all Chinese. Kind of cool experience. I've never had my name plastered with like a Chinese poster on it. So that was really neat. And then finally, every once in a while we get to go to like balls, like the Susan G. Komen ball right here that you can see. This is with Dr. Olapati. She may be speaking to you too. I do a lot of trials with her as well. And then this is with Komen folks and just us playing around with Susan G. Komen. So fun times. We love what we do. Okay. Now, I would be remiss if I didn't teach you a little bit about breast imaging because I know that all of you either are a female or you have a female in your life that's important to you. Many of you may even have been affected by breast cancer or know someone that may have been affected by breast cancer. So I'm going to teach you very quickly about all the things that we look for as a radiologist when we're doing mammograms and reading them. So just again, as a refresher, lifetime risk for breast cancer, 1 in 8 women. If you're at high risk, it's 20% risk, okay? So when we're looking and talking about breast cancer and breast cancer risk, there's many things that affect your risk for breast cancer, some of which you can control and some of which you cannot control. And the things that you cannot control, it's your gender. Being a female, you have a higher risk for breast cancer than males. Your age, the older you get, the greater your chance of breast cancer. 60s are the best decade to get breast cancer. Your genes, right? So if you have a genetic mutation like a BRCA gene that'll predispose you to having breast cancer, that's something you can't control. There's other things like your family history, at what age you had children, a menopause, and any exposure to radiation. Now, there's also things that you can control in terms of your risk for breast cancer. Things like having no children, giving birth at an older age, not breastfeeding, using hormonal replacement therapy. In all of this, there's been a new risk factor that's been emerging, and it's called breast density. And that's something that you cannot control. So let's talk a little bit about it. So breast density is a term that we use as radiologists. It comes in 4 levels or 4 categories. It goes from low to high. And it really just describes the proportion of white tissue, which is the glandular tissue, to black tissue, which is fat. And so you can see that as we march up these levels from fatty to scattered, heterogeneously dense to extremely dense, the mammogram looks to get whiter. Okay, so that means there's more and more breast tissue compared to the adipose tissue. The reason why we care for that is 2 things. 1, having greater breast density, so being at category 3 or 4, means that you have a greater risk for breast cancer. More breast tissue means more risk for breast cancer, right? So the more dense you are, the greater your risk for breast cancer. Second, having increased breast density makes it that much harder for me as a radiologist to see your cancer. Cancer is going to look white on a mammogram. So if your mammogram is already white to begin with and it's white on white, it can be hard for me to see. It's called a masking effect. And so having dense breasts increases your risk for breast cancer. In addition, we know that half the population has dense breast tissue. It's more common if you're younger. It's more common if you're of a skinnier sort of body habitus. And not only that, it's also become a national issue, right? So there have been national federal notification laws that are sweeping the nation. And you can see that all of the pink states have some sort of breast density notification requirement. That means that if you have a category 3 or 4 dense breasts, we have to notify you that you have that. And if you look at the diamond states, that means that those states have some sort of insurance coverage to help sort of give supplemental screening tools in the setting of dense breast tissue. So if you have dense breast tissue, you may say, well, you told me it increases my risk for breast cancer. What do I do? Well, there's different modalities and different things we can offer you. We can offer you an automated whole breast ultrasound, which means in addition to your mammogram, you can get an ultrasound of both of your breasts as a supplemental screening tool, or we can actually do an MRI. And so a lot of states just stop at the fact and they say, yeah, you have dense breast tissue, and they don't offer anything more. But with these diamond states, including Illinois, we actually provide insurance coverage. And lucky for us, Illinois has, oh, I thought I had that, I apologize. Illinois has actually the most progressive one of these insurance coverages. So not only do they allow for coverage for ultrasounds, but they allow for coverage for MRIs, right? So MRIs can cost up to $6,000 to $7,000, and you can get one for free if you have dense breast tissue. And so that's huge in Illinois, that's huge. So density is a really big thing, okay? That's genetic variations. Now let's talk about cancer variations. So in the world of breast cancer, it's not just one type. There are multiple different types, and we don't need to get into the nitty-gritties of them, but I want you to understand and appreciate that when we just say breast cancer, it's not a wastebasket term. They're actually different terms, and it has to do with the type of receptors that are on the molecule of the breast cancer, right? So we have luminal A's, luminal B's, HER2 enriched, and basal-like. And the reason why we even care about this is that they affect the type of morbidity and mortality that you have. As you go down this sort of subtypes, you can see that the grade of the tumor goes up and their long-term morbidity and mortality is worse off. And so it has prognostic information in the phenotype of the tumor. And so just very quickly, you can see that luminal A tumors on a mammogram will look like this. They'll be small little spiculated masses. Right here, you can see these little guys. On ultrasound, they're going to be, again, a black little circle, hypoechoic, with a little white halo around it. It's going to have blood flow on it. And then on MRI, it's going to be a small little unifocal mass. And so luminal A tumors are sort of the best type to have. They're the most common ones. They're low grade. They have the best overall survival. If we go up a notch to luminal B tumors, you can see they're slightly different. They're a little bit bigger, right? They have a lot more of these spiculations or straight lines coming off of the mammogram. So definitely starting to look more aggressive compared to luminal A. You can see on the MRI that it's not just a single mass, but there's all this fuzzy non-mass enhancement around it. Oftentimes the lymph nodes can be enlarged or involved. And so you can appreciate that on this ultrasound. It's a lot bigger, a lot more angular margins, a lot uglier looking. And the lymph node looks large with this cortical thickening. And so luminal B tumors have a higher grade. They have a higher rate of proliferation, more likely to have these lymph nodes. Then we march off to HER2 enriched, right? Herceptin enriched sort of tumors. And you can see that these, again, have very irregular margins, pretty decent big sized tumor. And oftentimes you can see, here's the ultrasound with these angular margins, but take a look. They can have small satellite lesions next door. And that's very, very common for HER2 tumors. And so here it is on the MRI. Here's the big lesion, and then all these little guys marching forward, right? So it's a mass and all of this non-mass enhancement. And they're oftentimes of a higher nuclear grade. They can be multifocal or multicentric, and they have an aggressive clinical course if not treated. And finally, there's this basal-like tumors, or what we sometimes hear as triple-negative breast cancer tumors. These are the most common in our young African-American minority females. We see a ton of triple-negative breast cancers here. And you can see, compared to the other types of tumors I've shown you, these don't look as spiculated. They may actually look like a circle, right? And so if you don't have breast fellowship training, take a look at ultrasound. You don't see those angular margins again. You don't see those spiculated margins again. This looks really round and oval, right? And so if you don't have breast fellowship training, you could confuse this for something benign because it just looks round and oval. You could say it's a cyst, and if you're not careful, you could miss it and you would not call it something suspicious. And on MRI, they have this classic sort of rim enhancement with the black center and a white sort of enhancement. This is a classic imaging biomarker for triple-negative breast cancers. And so these are the most aggressive. They're common in our mutation carriers. They're common in our young African-American females, and they're super aggressive. And so we've talked about genetic variation for breast cancer, things that we need to look into, like your risk factors for breast cancer. We've talked about the different types of imaging variation now in the different types of breast cancer. And now I want to talk to you about the different types of imaging modalities, right? There's a difference between the types of cancers that mammograms detect and the types of cancers that MRIs detect. And so MRIs, what kind of technology does an MRI use in order to obtain its images? Anyone? big magnets is one answer. Anyone else? What type of technology does a mammogram use? Ultrasound. So mammograms use X-ray technology. Yeah, you guys got it. The last two folks got it. It uses X-ray technology. It's exactly the same as a chest X-ray, right? So it uses X-ray beams that hit the soft tissue, hit the bones, hit the air, and it creates an image. It spits out an image. That's why it's so crude in its images. It's very black and white, right? So when the X-ray beam hits something of substance, it's blocked and it doesn't reach the actual receptor, the film on the end. That's why it's white. And when the X-ray beam goes through fat and it goes right through and hits the film on the other side, it's black, okay? So that's what creates the black-white image. And so you can imagine on all those prior pictures I was showing you that were mammograms, they're black and white, those are X-rays. Ultrasound is a whole nother modality. It uses sound wave or sonar energy. So the sound waves will go through the breast tissue. If it hits something that's malignant or like something ugly like that tumor lesion, the sound wave is absorbed and it turns into a black hole, right? That's why it turns black like that. So tumors will absorb that sound ray and it'll turn black. And MRIs uses a combination, as someone mentioned, of magnets and radio frequency energy. And so radio frequency coils will emit the energy into the breast. It'll interact with the tissues, and when it spits back out, it's collected by the coils. And the magnets help give energy to the whole system, okay? So we have 3 different modalities that we use in our breast world, and each of them gives us different information, as you can imagine, right? So when we hit the breast tissue with different types of energy, we get different types of information. How's it look?
So she went closer, got the second one.
Okay, let's take a look.
It's a little hard to tell the margin.
Say hi to my class, guys.
Hi, class.
I told them in advance, I'm like, I'm in clinic.
From a breast density.
Yeah. I was talking about disparities in breast cancer here, and then I said I would be remiss if I didn't teach them a little bit of breast imaging just to
Random
convince
is
them.
X-rays for whoever asked that question.
Hi, someone said. All right. 1, 2, 4, 2. All right, let's take a peek. Let's flip you. You can see me in action here when I flip you over. Let's some of the words. Okay.
So these last, and the one before this.
Mm-hmm. So that's our, oh, there's our little cluster of calcs.
Exactly.
Uh-huh.
So it's good. And then that second to last
And then
one,
what about up here?
yeah, so that's the margin. for
Got
this
it.
guy.
Oh, I understand. And that didn't have anything.
And so this was unable to be on its side.
I couldn't
Too
see
small.
that side.
Mhm. But, okay, so we definitely got these little guys, which is what we were kind of targeting, right? So they were along this margin basically, and then this margin was.
And I'm really excited about that whole corner where
That's
the
it.
sickle is. We look at that again, there's nothing in it.
Nothing in it. There it is.
And then this last one is
That's the anterior near the wire entry site.
Mhm.
It's just that. And again,
Soviak,
Cool.
okay,
that doctor
All
just.
Great.
and may I please be excused?
Yes. Okay, we're back.
Was that Nora?
Yeah.
Who is that?
Dan Colden.
Hi, Dan. Hi, everyone. They heard from me last week. All right, bye.
Bye.
We really
Okay, awesome.
work together.
Oh, that's awesome. Yeah, it's multidisciplinary at its best right here. Okay, so as we're talking about, we've talked about genetic variation, tumor variation. Now we're talking about imaging variation. So I'm trying to paint the picture to you that this is all the different types of information that radiologists have to sort of process in their heads when they're looking at a patient's imaging protocol, right, or imaging sort of portfolio. And so when we talked about the different types of modalities, mammograms use X-ray technology. So you can imagine it has a modality inherent bias to detect slow-growing cancers, right? The way that we detect cancers on mammograms, like I pointed out before, is these spiculations or these straight lines or these masses. And these spiculations and masses only come up after the tumor has had time to grow, right? It's turned from a microscopic process to a macroscopic process. And the spiculations are actually the body having a desmoid fibroblastic reaction, trying to sort of block this tumor and keep it enclosed. And so the tumor is responding to it. So all of this takes time, and all of this means that a mammogram detects things that are slow growing tumors. And so oftentimes when we detect these cancers at the 1-year time marker at their screening mammogram, we know that it didn't develop last night or last week. It took several months to develop, right? And like I said, these processes of spiculations and distortions and masses all reflect hypoxia, necrosis, and fibrosis. Okay, let's compare that to MRIs. Now, MRIs, because of the way that we detect things using radiofrequency energy, magnet energy, and the injection of this contrast, we detect things that are biologically active and prognostically relevant. So when you come in for an MRI, similar to a CT, you're going to get a little IV placed in your arm, and we're going to give you some contrast agent. This contrast agent is going to be picked up more so in things that are very actively growing, or that things that have a lot of blood supply, like cancers. So cancers, when they're growing, help develop a lot of blood flow to them to bring in food and nutrition. And that's going to pick up the contrast very, very quickly compared to benign breast tissue, which won't. And so the concept of how we detect cancer in MRI is very similar to what I just said. It's a combination of this angiogenesis and a combination of protease activity. When a tumor is growing, it's going to need food. It's going to bring in a ton of these vessels to it. It's going to recruit vessels, and it's going to build vessels. So it brings in a lot of these vessels. However, the vessels that it does build are not of good quality, right? It's from a tumor. They're going to be leaky. And so this combination of a lot of vessels, which brings the contrast in, and leaky vessels, which leaks all the contrast into the tumor, leads to avid contrast enhancement. And that's how we can differentiate from good from bad. And so the fact that we see something in MRI reflects its underlying process of carcinogenesis, cell proliferation, this ability to have metastases, right? You can only have metastases if you have vessels that allow it to carry it to other parts of the body. Okay. So we put all of this together. We come to this concept of personalized medicine, right? How do we put all of this information together to come up with the right screening tools for the right patient? And so we now know all of this information. You guys know all of this information. How do we break it down to a way that makes sense? So basic guidelines. If you are an average risk female, that means you have 12% lifetime risk for breast cancer, you don't have a significant family history for breast cancer, you don't have a personal history of breast cancer, you should get a mammogram. You should get it every year starting at the age of 40. Now, you're going to tell me, okay, that's great, but what about this whole density thing? Because you just told me density matters, right? So that's right. So if you have lower density, I don't want you to worry about it, get your mammogram every year. If you have higher density, then in addition to getting the mammogram, you should ask for these supplemental screening tools that I mentioned, right? And in Illinois, you should definitely ask for them because they're covered. They're covered because of this national laws. So you should ask to get an automated whole breast ultrasound, or you should ask to get an MRI. If it's covered and it's going to find these cancers that may be hiding in your dense breast tissue, then why not, right? That just gives us an extra opportunity as a radiologist to find tumors at a much earlier stage and help with your long-term survival and morbidity. Okay, how about if you're a high-risk female? So you have a greater than 20% lifetime risk for breast cancer. Of course, you're going to need that mammogram, right? And depending on your breast density, you can get the supplemental screening that we talked about. But in addition, we want you to get an MRI. You are eligible to get an MRI if you're greater than 20% lifetime risk for breast cancer, okay? And it doesn't matter if your density. And so this is an MRI image. What side looks abnormal to you guys, right or left? Shout it out. Valerie says right. Anyone disagree, agree? What are we thinking? Okay, yeah, it's the right side. Great job, you guys. All these little white guys, you see, this is all tumor. And you can see there's slightly extra vessels, all these like tubular dilated things feeding into it. Some of these are feeding arteries, some of these are draining veins, right? Coming in and out from the internal mammary vessels. So this is all tumor, okay? How about this, right or left? Right again, anyone else? Yeah, there you guys are. Here it is. This is the right side. Perfect. How about this, right or left? Kevin says left. Maria says left. Great. You guys are all breast radiologists. You don't even need me, right? but this is how powerful MRI is. Look how small these lesions can be. We can detect them up to 2 millimeters on an MRI, 2 millimeters. And breast density just doesn't seem to matter, right? You can clearly penetrate through that breast density with a simple MRI. And so if you have dense breast tissue or if you have elevated risk for breast cancer, you should get an MRI, okay? Now, when we talk about why doesn't everyone get an MRI? If I just showed you that it looks so amazing, it's so easy to read, it's so easy to interpret, why aren't we doing it on everyone? Big thing is cost, right? It always comes down to the cost. A full MRI takes about 20 minutes to acquire. It's a timed dynamic acquisition, which means we get 1 pre-contrast and 5 post-contrast images. We inject this IV contrast and we watch the march of contrast flowing in and out of the breast or in and out of the cancer. When radiologists say, oh, it's such an amazing tool, we should all do it, people say cost. So what did we do? We came up with something called a concept of abbreviated MRI, and I'm going to talk to you about that in just a second. This talks about the kinetics of cancer. So as I've mentioned a couple times now, cancer will pick up this contrast very, very quickly, and it'll wash it out very, very quickly. Normal tissue would pick up this contrast and just keep picking it up. It's a very slow process. And so this difference in contrast kinetics is what allows us to see these beautiful, bright enhancing lesions. And just a little bit on the sensitivity and specificities of these things, you can see that if mammograms catch about 40% of cancers and ultrasound catches about 40%, MRI beats it out of the water, right? Doubles that, 80%. And so what we did when we realized that cost was an issue, we came up with this concept of an abbreviated MRI. That means we only acquire 1 pre-contrast and 1 post-contrast image. That's it. It takes 5 minutes to do. At the University of Chicago, this costs $125. The cost of a screening mammogram for Medicaid is $250. So an MRI can cost less than a screening mammogram at the University of Chicago if you do an abbreviated protocol, right? Now, some of you guys that were looking at that kinetic curve that I showed earlier were like, well, wait, if you just told me that you need the whole kinetic curve to figure out whether something is good or bad, you need to watch the flow of contrast in and out, how are you going to do that if you're not acquiring those images, right? How are you going to get to this little kinetic curve right here that I talked about? So what we do here at the University of Chicago, we add what's called ultrafast images. We add these 3-second temporal acquisitions within the first 1 minute. 3 seconds. So in 3 seconds, we can scan both breasts with MRI. And what we're doing is we're creating extra time points to really look at a pseudokinetic curve and look at the super early time point to see whether something is benign or malignant. So pictures speak 1,000 words. In this image, this is at the 1 minute time mark. So a regular 1 minute time mark MIP. And it's hard, right? Like what side looks abnormal? I don't know. I couldn't even tell you. It just looks all white to me. I can't decipher it. But if I go backwards in time, so now I'm subtracting 3 seconds and showing you these ultrafast images that are 3 seconds long, you can very nicely see at a really, really early time point, the cancer comes right out, right? Like it's just right there. It's staring at you. And that's because it's at such an early time point that only the cancer has picked up the contrast, but not the breast tissue. And so this concept of abbreviated ultrafast MRI has really now started to revolutionize things. I think in 5 years, maybe 10, we'll only be doing abbreviated MRIs. That's it, because of the cost and because of this diagnostic equivalency to a full MRI. And also just patient convenience, right? Like if you are claustrophobic or you just don't like being in this little small donut, most times patients can tolerate a 5-minute scan as opposed to a 20-minute scan, right? And you can imagine from a hospital perspective to have a scan that only costs $125, only takes 5 minutes. So traditionally we have 2 patients scanned per hour. If you can now double that even, or even quadruple that, the patient's throughput and the volume throughput markedly increases. So for the hospital, that just means generating revenue for them, right? And they're gonna buy into this right away. And so, here's just another example of that. So here's at the 1 minute time mark. And maybe you think that these are some abnormal lesions right here, hard to say, but as we subtract these 3 seconds, you can really nicely see that she not only has 1 cancer, but multiple cancers in both breasts. Really kind of cool. So one of our trials is called a CAPS trial, the Chicago Alternate Prevention Study. And this is one of the SOAR, our disparity grants that we got from the NCI. And really what this is we're looking at 400 high-risk women. So you have to have this greater than 30% lifetime risk is what we're saying. And you have to have a presence of a genetic mutation. And what we're offering them is these biannual abbreviated MRIs. So when we talked about these young minority women, we said that these young African-American females were predisposed to aggressive cancers, fast-growing cancers. What we also noted was that annual screening was just not enough for them. So even when they came in for their annual mammogram, their annual MRI, they followed all the guidelines. They were still coming in, perhaps sometimes in between these screening intervals with fast-growing cancers. And they would say, well, I just got a mammogram in January, but I'm feeling this mass now and it's May. And those cancers are called interval cancers because they happen in between their screening rounds. And because they developed so quickly that they actually became palpable for the patient, they're the aggressive ones. They're the triple negative tumors. And so we decided, what if we do a trial with biannual MRI, right? So twice a year. Now, you may think intuitively that makes perfect sense. Why don't we just do that? But then there you have to think about the issue of cost. A biannual MRIs of full length costs a lot of money. That's a lot of money of grant money that you need. So we changed it to abbreviated MRIs. So abbreviated biannual MRIs. And what we were able to see is we have some preliminary data already that I can talk to you guys about. So we followed some of these ladies now for 3 years. We have detected 17 cancers in 200 ladies, 6 of which were seen at the 6-month time mark. So had they not had that extra MRI, which is not part of their normal NCCN guidelines, we would have potentially missed it or it have gone undetected for the next, until their next screening mammogram. So these were interval cancers that we detected using biannual abbreviated MRIs. It's still an ongoing trial. We're following them for 5 years. And so if you or anyone you know is at high risk for this, we highly encourage you to reach out to me so we can get them enrolled. We're really focusing on minority women. We're focusing on African-American females and Hispanic females, just because we know that they are the ones that are prone to getting these interval cancers. And the fact that it's only an abbreviated MRI, it hopefully makes it a little bit more accessible. We are not only just doing this at U of C because we understand it could be a burden to come all the way to U of C, even when we do provide transportation. So we are offering this now at Ingalls. We're going to roll this out at Silver Cross, and we're going to roll this out at our offsites, including Orland Park and River East. So we're really trying to increase our catchment area to make sure that this is something that all patients, if they're eligible, can have access to. And it's completely covered by the study. So we want to really try to improve our overall patient compliance, our access to these studies, and improve this workflow so that we can do abbreviated MRIs nationwide. And then the last study that I want to talk to you guys, and it really has to do with this concept of personalized medicine. It's called the Wisdom Study. It means women informed to screen depending on their measures of risk. This is a national study. They want 100,000 women to enroll, and we are the first partner in the Midwest to be part of this. And what this is you have a choice. As a female, you can enroll on there. It's totally free to do it. And if you choose the personalized arm, they will send you a saliva kit for free. You will spit in it, and 2 weeks later, you will get your own personal genetic risk for breast cancer, right? They test for over 90 genes in just your saliva. Based on that personal risk, we will assign you a very specific arm for imaging. So if you're at ultra low risk, we may say start mammograms at 50. If you're at medium risk, we may say start annual mammograms at 40. If you're at really high risk, we may say you need biannual MRIs with mammograms. Joseph, I'll come back to your question in just a second. And then the other arm for that is just a randomized arm. So you can choose to just follow USPSTF guidelines, or you can choose to be randomized into this precision arm. And what they want to see is that not only is this personalized arm going to be just as safe as following the USPSTF guidelines, but to make sure that it's cost effective. So only allocating the high-end resources like these MRIs to the patients that really need it, and to make sure that it's just as effective, that we're catching these cancers at stage T1 or less, okay? And so it really is a revolutionary way. We've never tried to do anything like this before. It's a personalized approach to breast cancer screening. And we're trying to see whether this provides, like I mentioned, greater healthcare value. And so let me jump back to Joseph's question. Is there a control group in CAPS? And if not, how did you all weigh the pros and cons when deciding to go with a single arm? Yeah, so this CAPS is sort of it's been a phased experiment, to be honest with you. And so we know that the NCCN guidelines for these high-risk patients greater than 20% is annual MRIs, right? And that's just, we know that that is standard of care. When we were looking at these patients at our University of Chicago, we saw that even when they followed standard of care, they were still coming in between their screening rounds with these aggressive cancers. So we knew the annual was just not enough for them. And so then what we did was we did this trial called MRI 1.0, where we offer them biannual MRI. So we doubled what was required for NCCN guidelines, and we offer them biannual full MRI scans. And we saw that we were catching more cancers even at this 6-month time mark, and we were catching them at a much earlier stage than had that 6-month time mark MRI not happened. We published on that, and we know that that works. Then while we were publishing it, there was this whole trend of abbreviated MRI started coming up. And abbreviated MRIs were starting to be offered in all different patient cohorts, including patients with dense breast, patients with history of cancer, patients at high risk for cancer. And all of these papers, one after another, were showing that abbreviated MRI was just as diagnostically equivalent as a full MRI. We were not missing out by excluding part of this scan or excluding part of these sequences, that it was just as diagnostically equivalent. So now with this trial, we are now taking these biannual full MRIs and converting them all to biannual abbreviated MRIs. And that's based on this progression of all of these studies that we've done and this progression of this data that's come out from abbreviated MRIs. You know, and so of course these patients on the CAP study have an option to opt out and just go back to the regular annual MRI and mammogram as recommended by the NCCN. But with this trial, they're getting increased surveillance more than they would. It's more than the standard of care. And so most of our patients stay on this because it gives them that extra added comfort. Does that answer your question, Joseph? Awesome. Any other questions that anyone else has while I pause here? I know I've been talking for a long time, so I apologize, and I will end it in just 2 minutes.
Actually, I apologize. We should have told the students this before. Actually, our next speaker conveniently is not coming till 4:30. I apologize for not notifying everyone last week, but hold on, Anna. So Dr. Sheth will finish, then we'll take a break, and then Dr. Hassan should be here at 4:30.
Yeah. I'm going to finish in just 2 minutes. I'll let you guys all like unwind a little bit because I know it's hard to listen to a screen for an extended period of time, and I totally get that. And so these are the 2 main trials that I want to talk to you guys. I've already followed it pretty much. So really we now circle back, right? So you guys have learned a lot of different things. You guys have learned about disparity. You've learned about breast cancer disparity in the US and amongst African American females versus Caucasians. You've learned about breast cancer disparity as it relates to Chicago and how huge that gap was back in 2002, and the efforts we've tried in multiple different ways, including task force, including collaboration with the community in like Chinatown, including these clinical trials that sort of favor over recruitment and over accrual of minority patients to help change this mortality gap that we have. And then you've also learned about how we come up with clinical trials, right? Like how do we process all of the different information that we know, including your genetic variation, your tumor variation, your imaging variation, how we come up with things that lead to personalized medicine or precision medicine, and also cost savviness and economic feasibility, right? Because that we have to be mindful of that. And so it's really been a paradigm shift. Back 40 years ago, when they were first realizing that screening mammograms worked, it was just a blanket statement, one size fits all. Everyone should get a mammogram starting at the age of 40. Some say 50, some say 45, whatever, right? But it was a blanket statement, one size fits all. And we have so much controversy over when to start mammograms, stop mammograms, and that's because we are realizing that no one person is the same. So it's hard to have these blanket statements and blanket guidelines because some people will fit that and some people won't fit that. And so there is this trend now, including with Wisdom Study, to personalize this. Find out your risk for breast cancer before you get breast cancer, right? Preventive oncology, figuring it out before. And so if you look at this chart, you can see that based on what we've talked about, there are different types of breast cancers. Some grow really fast, some grow really slow, and some never progress, right? And if we had a study or a guideline that screened everyone at one specific time, like screening mammograms at the age of 40, we would catch all of them. There's no denying that, right? I'm not saying that we wouldn't catch any. We would catch every single one of these tumors. However, do you have to catch all of these tumors? That's the question. If some of these never really turn, like all these DCIS in situ cancers, some of them don't even turn to invasive cancer. Was it really worth it to the patient, to the economy, to healthcare system to have caught that cancer, right? It's this concept of overdiagnosis. So if we now take into account all of the knowledge, this genetic risk, imaging variation, tumor variation, and we only screen for cancers or in patients that need it the most and catch the cancers that are the most clinically relevant and prognostically relevant, then potentially we're getting to something where we have maximal effect with the clinical trials, the best sort of cost feasibility, and the best sort of adherence to these protocols, right? If females know that they are at high risk for cancer, they're more likely to adopt that and follow that guideline than if you just say everyone should get it at the age of 40. And so you will start to notice these clinical trials, even in the world of imaging, really are starting to do this sort of precision medicine. And that's what the CAPS is all about. That's what all the wisdom is all about. And they're using the technology, the advanced technology and the advanced imaging that we have with tumor biology and genetic risk. And then there's a lot of AI to it too. So if you guys are ever interested in that, just let me know and I can help you with a project for that as well. But coming back to our intentions that we started with, right? This concept of risk stratified breast cancer screening is a paradigm shift, as we've noticed. We want to adapt our screening efforts to the individual female's lifetime risk to develop breast cancer. We want to try to really close the gap in breast cancer deaths among minority women. We want to try to leverage our institution's strengths in genomics and imaging and bioinformatics, along with our key location on the south side of Chicago to make major impact on cancer disparities. And finally, we want to try to translate this cancer health equity into action, right? We not only just want to say we have all this amazing research here at the university, we want to bring that research out to the community. We want to collaborate with our community, collaborate with these stakeholders, and collaborate across disciplines, right? I showed you pictures of Dr. Olapati, Dr. Jaskowiak was here. We all work together to try to promote, prevent, and detect cancer in order to reduce the cancer burden and the impact that it has on our neighbors. So that is it for me. I know I covered a lot of different things. If you guys ever have any additional questions or you want to work on a project, you're interested in learning more, please just email me. I'm always here. I'm always here. So I'm more than happy to work with you on something or talk to you more. We have a question from Kevin. It says, how often are breast cancer risk assessment surveys used in clinics? Are they typically personalized to the patient, bracket tool versus, okay, yeah. So so genetics is going to be a huge deal. We actually just started a new trial where we are screening women in our screening room. And if they meet preliminary guidelines to get genetic testing, then they will get genetic tested with saliva. And so what we do is we ask them just 3 basic questions, you know, like if you have a personal history of breast cancer, if you have 2 direct family members with breast cancer, if you have 3 direct, but also with pancreas and ovarian, then you are eligible for genetic testing. If they meet that quick criteria, we have an iPad in the screening room. If they meet that, then we have a student come in, they spit in that, we send that off for genetics, and in about 2 to 4 weeks, they get a result. We also have genetic counselors then that reach out to those patients and do a virtual visit, especially in the time of COVID, but eventually it'll be an in-person visit. And if they meet criteria for any of our trials here because of dense breast, because of their high risk, because of whatever, then we put them into those trials, and we also then get them into our high-risk clinic. So yeah, that's becoming a huge deal. We are wanting to do breast cancer risk assessment on every female by the age of 30. That's going to be the trending thing. That's what NCCN wants us to do. So there's a big push with the hospital to get that done as well. Any other questions? Thanks guys for paying attention. I appreciate it. I know it's hard to do that in the afternoon and through a screen. And so I appreciate you guys being engaged and interactive, asking me questions. And like I said, please take down my email address. I'm more than happy to answer. I was in your spot once upon a time too, not too long ago, Dan and me both. And so reach out to us if you need anything.
Yeah, so thank you so much, Dr. Sheth. That was great.